Hi, my name is Haley Miller, and I did my project on cultural humility um, in like a healthcare setting. So I'm going to first go start by just kind of skimming through my implementation plan. Um, I started out by saying first, it's very important to understand that cultural humility is developmental. This is not something that we can teach and expect our students to learn overnight. It's something that's going to be needed to be taught and reinforced daily, weekly, yearly, not in just a one-time training. So then rather than placing the training into a single course, cultural humility competencies will be integrated across the whole curriculum. So year one, preclinical phase, you're going to see this being taught in your introduction to clinicals and healthcare ethics course. And then here you can see kind of how you'll teach it. And then your evaluation for it. Year two is your applied clinical integration. Here, you're going to see that taught in your health assessment, pathophysiology, your actual clinicals, and your simulation labs, how you'll teach it, and then how you'll evaluate it. And then during actual clinical rotations, you'll see it in your clinical rotations, your community health experiences, and then lastly, in your internships, how you'll see it, and then your evaluation of it. So that is my implementation plan. And then we'll get into the training. Let's see here. Okay. So, cultural humility in the clinical practice. So, cultural humility versus cultural competence. Cultural humility is a lifelong commitment to self reflection and self critique aimed at understanding one's own biases while building respectful, authentic partnerships with diverse audiences. That's from JPA Health. Just a neat little picture I found that kind of, I thought, played well into this. So, why does it matter? It builds trust, it avoids stereotypes, it improves communication, and it allows for error. And then cultural competence is the ability to understand, appreciate, and interact effectively with people from different cultural, social, and economic backgrounds. That's from BCT Partners. So, why does that matter? It improves relationships and communication. It creates an effective workplace and business. It enhances health outcomes, and it reduces bias and prejudice. So, bias scenarios, I'm going to go through one scenario so you guys can kind of see how I would actually teach it, but I did include scenarios for each topic. So, for the first topic, it's patient assessment and diagnosis. So, the patient is Miss Brown, a 57-year-old African American female. She comes to the local ER with chest pain, shortness of breath, and is very lethargic. The nurse notices that Miss Brown is overweight and is on medication for a history of hypertension. Based on stereotypes about lifestyle habits related to African American females, the nurse makes the assumption the symptoms are probably related to stress or anxiety rather than cardiac issues. The impact of bias here is the nurse doesn't perform a thorough cardiac assessment. She delays notifying the provider, which then delays the EKG and cardiac lab. And then Miss Brown's concerns are minimized, which affects her trust. The outcome of this is delayed assessment leads to a late diagnosis of a myocardial infarction, also known as a heart attack. And then treatment is initiated, but unnecessary complications could have been avoided with a timely recognition. The reflection and learning off of this exact scenario, recognizing the implicit bias. So the nurse reflects on the assumptions made based on race and weight and understands how these affected judgment. The structured assessment using a standardized tool and checklist for chest pain can reduce the influence of bias. And then patient centered communication, actively listening to the patient's description of symptoms, validating her concerns, and avoiding assumptions about lifestyle are crucial. And the cultural competence and equity related to this is awareness that serious conditions like heart attacks may present differently in diverse populations can help the patient ensure that she's going to be getting that equitable care. So then for, oopsies, for treatment recommendations and adherence is my next topic. That's your patient situation. Everything is going to be the same here. and then your reflection and learning based off of this specific case study. The next topic was patient-provider communication and trust. This is another scenario. And then the reflection and learning based off of that scenario. The next topic is pain management and symptom evaluation, and the scenario that goes with this. And then the reflection and learning based off of that scenario. Health disparities and outcomes is the next one. And the scenario for that. And then the reflection and learning based off of that scenario. Okay, and now we're going to go into the mitigating biases in a clinical setting. So, increased awareness of implicit bias. So, studies show that implicit biases can influence clinical judgment, communication, pain management, and treatment decisions, even among well-intentioned providers. Strategies for this are complete validated self-assessments, engaging in structured reflection after challenging encounters, and participating in reoccurrent bias training. And this works because awareness does not eliminate bias, but it does reduce the automatic unchecked decision making. Then using standardized clinical protocol and checklist. Standardized tools reduce variability in care and decrease reliance on subjective impressions. So some strategies for this is by using the uniform pain scales for all patients, following protocols for your chest pain, sepsis, stroke. That's why we have them. And then applying evidence-based screening guidelines universally. Why does it work? Structures, processes, reduce opportunities for bias to influence triage, diagnosis, and treatment decisions. Practice perspective taking. Research in social psychology shows perspective taking reduces stereotyping and increases empathy. So some strategies, you can ask what barriers might this patient be facing, using open-ended questions and then considering the social detriments before labeling non-adherence. And it works because curiosity interrupts assumptions and promotes individualized care. Using patient-centered communication techniques. Patient-centered communication improves trust, adherence, and outcomes across diverse populations. Strategies are to sit at eye level, avoid interrupting, reflecting what the patient says, and avoid that stigmatizing language. And this works because trust reduces disparities in follow-up, adherence, and engagement. So some self-reflections tools that I would use are reflection journals. Very, very important, I feel. How it works, and then the examples of what I would ask. And it's effective because it allows you to think hard about exactly what you're thinking. Then I would also do the cultural humility triangle. I'm going to include a picture of this just so it's easier. You have the self-awareness, the power awareness, and the openness to learning. And then another one is the reframing language activity. Obviously, you see a lot of non-compliant drug seeking, frequent flyer, poor historian things in charts, and we want to get away from that. So having the students write them in different ways. And then this builds awareness of how the documentation reflects the bias. And then lastly, the bias pause self-check card. I think this is so cool. They can carry a card with them that helps them think about certain things, but the pause it, pay attention, acknowledge your assumptions, understand your perspective, and seek different perspectives, and then examine your options and make a decision. Check yourself before you listen. Pause to notice your emotions and biases. When you're aware of your inner state, you're less likely to interrupt, judge, or get defensive. And then your important reminder, one of the goals of cultural humility is to create spaces for healing and equitable learning so that all are seen, heard, valued, loved, and supported. And then I'm going to go into here as well. Measuring cultural humility requires assessing growth in self-awareness, behavior, and relational skills, not just the knowledge of cultural facts. And I plan to use a structured competency-based approach aligned with 4 methods. The first one being reflection assignments. This measures self-awareness and growth. Specifically, I'll measure my students' ability to identify personal biases, self-reflection, and show evidence of behavioral change over time. I'll measure this by using a developmental rubric based off of bias recognition, depth of reflection, and ownership and application. The second one being clinical observation rubrics. This measures their skills in person during clinicals. Specifically, we'll measure communication behaviors, the power awareness, the respectful engagement, and adaptability. It will be a pass-fail rubric. The third one will be case study analysis. This measures clinical reasoning and bias awareness. This specifically measures the ability to identify where bias may influence care, the recognition of the structural factors, and focuses on care planning. I'll give my students case studies, and they'll need to be able to identify potential biases within these case studies. And then the last one would be the peer discussions and debriefs. Very, very important when it comes to clinicals. This measures interpersonal humility. Specifically, this measures openness to challenge, emotional regulation during difficult conversations, and respect for diverse perspectives. I think it's very important for my students to understand that cultural humility is developmental. This is something that everyone constantly is growing in. And as long as I see my students growing, the goal is achieved. My project will target 4 of the Nebraska human relations training skills. The first one it will relate to is Nebraska skill number 2, the ability to recognize and deal with the dehumanizing biases, including but not limited to sexism, racism, prejudice, and discrimination, and an awareness of the impact such biases have on interpersonal relations. I think this is pretty straightforward. I'll teach that we treat each patient with dignity. The second skill my project will include is number 5, respect for human dignity and individual rights. This is also very straightforward when it comes to a clinical setting. I'll instruct that each patient has their own rights and that we'll respect them as nurses. I'll also teach that when patients are admitted into the hospitals, they are given their own patient rights. The third skill I will include in my project is number 3, the ability to translate knowledge in human relations into attitudes, skills, and techniques, which result in favorable experiences for students. Here, I will help my students find and understand ways they can be empathetic, respectful, and have the patient-centered attitude in the clinical setting. The last skill I will include is number 6, the ability to relate effectively to other individuals and to groups in a pluralistic society other than the teacher's own. I will include this by sharing patient scenarios, simulations, and self-reflection tools. While yes, it is important to share personal experiences, it is also very important to relate to society. Thank you.